consideration regarding lumbar spine fusion, which I think is very important. We continue to assess, reassess, evaluate, and do research on even the most common of procedures, because that's the only way we'll improve, and there is nothing we do that's good enough yet. So with that preamble, Bill, could you begin? Thank you.
Absolutely. Good morning, everybody. My name is Bill Kemp, neurosurgery spine fellow here at UW for this academic year. It's my pleasure and honor to present neurosurgery grand rounds today. My talk, consideration of materials and approach in fusing the lumbar spine, will hopefully grant you a better understanding of what entails a lumbar spine fusion and allows us to provide optimal care for our patients. I have no disclosures. These are our objectives today. We will discuss why we fuse the lumbar spine, how we fuse the lumbar spine, the spectrum of approaches available to us, and of course, the future. This is an ambitious talk, make no mistake. We have a lot of material to cover in 45 minutes. Some of these topics could be grand rounds lectures in themselves. Interestingly and alarmingly, in terms of public opinion, it's a controversial topic. As spine surgeons, it's important to be aware of how the public perceives what we do. Lumbar spine fusion has been accused of being a surgical treatment performed with wide variability and also accused of having a questionable efficacy. You'll only have to look at news articles from the last 20 plus years to get an idea of what the public thinks of spine surgery. Every now and then, though, spine surgeons get it right when it really matters, as it happened with Tiger Woods with his prior MIS L5S1 fusion. We are focusing on the lumbar spine because low back pain is the most prevalent problem that will affect 99% of Americans at some point in their lives. It's the most prevalent reason for why people have sick days. Patients will come to us and ask us with back pain, do I need surgery? And we have to have an answer for that. Let's get philosophical though. How do you approach a problem? When it comes to fusing the lumbar spine, it's important to ask how often do you consider approaching a complex problem from a different perspective. We actually do this on a daily basis, whether it be cranial or spine surgery. The ability to customize operative spine care for patients is exciting, and frankly, what I think makes spine surgeons passionate about their craft. Possessing a wide surgical armamentarium is paramount to providing the very best care for our patients. Shown here are the posterior and lateral illustrations of the lumbar spine with relevant anatomical features labeled. In particular, the posterior view is usually the introductory view of the lumbar spine for young trainees and the workhorse approach for spine surgery. Understanding this lumbar spine anatomy is key to understanding why and how we fuse the lumbar spine. The first objective, why fuse the lumbar spine? It's a well-established treatment for the degenerative disease, as you can see here, for an L4-on-5 spondylolisthesis, which describes the anterior displacement of one vertebral body over another, often in case due to a fracture of the pars interarticularis, the bridge of bone between facet joints. And this patient had an L4-5 instrumented fusion with the inner body placed. It's also indicated for trauma, in this case from a motor vehicle accident where there was an L3 burst fracture with an L3 corpectomy and fusion from L2 to 4. Sometimes it's indicated for infection, in this case in a patient with tuberculosis causing osteomyelitis of L1-2 requiring a thoracolumbar fusion. And even sometimes in the case of neoplasm, shown here as a patient with breast cancer metastatic lesion in the right L5 vertebral body, encroaching on the right L5 foramen, requiring decompression and ultimately a lumbar sacral fusion. These patients will exhibit signs and symptoms of radiculopathy, neurogenic claudication, motor deficit, sometimes even myelopathy if the conus is being affected at L1. But be wary of fusing for solely back pain. Different techniques exist to achieve fusion. Different materials, implants, and approaches are rapidly emerging. And it is important to note that evidence is often not clear for definitive superiority of one approach over another. The purpose of fusing the lumbar spine is to achieve stability, whether it be from acute instability in the setting of trauma or glacial instability in the setting of degenerative disease. We will often use a bone graft, either an autograft or allograft, with the hopes of achieving an osseous fusion. This would be supplemented with implanted instrumentation. And then it's off to the races. It's a time challenge between failure of the implant and osseous fusion. Eventually, the implanted instrumentation will loosen. Hopefully, osseous fusion is achieved before that happens to avoid pseudoarthrosis, in other words, a failed fusion. This graph illustrates the relationship between mechanical stability of implant relative to new bone formation. The second objective of this talk, how do we fuse the lumbar spine? There are some important concepts to discuss in fusing the lumbar spine. The first of which is osteoinduction, which describes undifferentiated cells which are stimulated to develop in a bone-forming lineage. Osteoconduction, which refers to bone growing on the surface of an implant or down into pores or channels. This electron micrograph shows the threads of a screw with new bone forming. This phenomenon, however, can be short-lived. After osteoconduction, there's osteointegration, which refers to the direct contact between living bone and implant, which maintains anchorage over a longer period. Shown here is a hydroxyapatite-coated vertebral screw in a goat, which shows bone anchoring. And then there's Wolff's law, which I think all the residents are familiar with. Describes tension and compression cycles, which create electrical potential that causes bony deposition and increased density at stress points. The other way we achieve fusion in the short term is with instrumentation pedicle screws. Instrumented pedicle screws were first placed back in 1963 in France. At the time, they were monoaxial coupled with plates. A gentleman by Roy Camille created them in the first place, started using them in 1963, but didn't publish his results until 1970. In the 1970s, Paul Harrington came up with the Harrington rods, which were used to correct spinal deformity, degenerative disease, trauma, and metastatic disease. They could correct coronal deformity, but often led to loss of sagittal balance. In the mid-70s, another gentleman by the name of Eduardo Luque advanced the idea of fixed segmental fixation. And then in the 80s, Art Steffi popularized this technique in the United States, where he used pedicle screws with a contorable plate. At the same time, in France, Yves Cottrell developed a screw rod system. Rods were more flexible, and they left more room for fusion and did not violate adjacent facet joints, and this became the favored technique as used today, despite the fact that plates were considered stronger. Shown here is a picture of the Platen screw system developed by Roy Camille and popularized by Art Steffi. The residents and the staff for spine are very familiar with placing instrumentation for pedicle screws via anatomic landmarks. I've shown these diagrams aimed down the pedicle to maximize screw-bone interface. The other way we achieve osseous fusion, besides interbody, is with lateral inner transverse fusion, dorsal onlay grafting, where we decorticate the transverse processes and placement of autograft allograft bone. The advantages is often not feasible to do interbody cage at every level. Disadvantages is that it's non-weight bearing. Fusion rates are typically decreased relative to interbody cages, and the dorsal bone volume decreases with time post-operatively if it's been longer than a year and a half. So why use an interbody? There are theoretical advantages compared to dorsal onlay grafting techniques. Decreased incidence of pseudoarthrosis, increased rate of fusion, a restoration of anterior column stability, increased axial load bearing with ventral placement of the graft, and bone graft containment for arthrodesis. In addition to this, really complements what we just talked about earlier with Wolff's law. A brief history of the interbody cage. Initially developed in 1988 as a treatment for cerebral spondylotic myelopathy in horses. In 1996, FDA approved the use for humans in certain spinal disorders. In the mid-90s, we started using threaded cages, but they had high rates of subsidence. In the early 2000s, we started using non-threaded cages, titanium and PEEK being more common, but they had greater stability in flexion, axial rotation, and bending. This is just showing an example of a complication from my chief year last year, where we went too far with an interbody with a T-lift. So interbody does not mean in the body. In terms of materials, we use titanium for the interbody cages today. Low density, corrosion resistant. The surface can be modified to assist with osseointegration and adhesion. You can also use PEEK, being radiolucent, bioinert, MRI compatible, and an elastic modulus that approximates that of bone. We also use a compound called bone morphogenetic protein. A growth factor belongs to the transforming growth factor B family, causing differentiation of stem cells into osteoprogenitor cells. Approved by the FDA in 2002, initially just for A-lifts, L4 to S1, but popular to use for posterior lateral anterior transverse fusion for and to reduce the need for autograft harvest, which can lead to further complications. One of my mentors back in residency showed that over 2 years, the use of BMP achieved greater fusion than without BMP in all approaches in the lumbar spine. I'd be remiss to talk about fusion without mentioning how we achieve that besides just using anatomic landmarks. We also use neuronavigation in the placement of pedicle screws and interbody grafts in the operating room. This technology has been paramount in the OR. First developed in the 1990s, it's truly a patient safety measure that has improved screw accuracy, maximized screw diameter relative to the pedicle, reduced injury to neurovascular structures, reduction of radiation to the OR staff and surgeons, and reduction of operative time. Prior study showed an error rate of at least 15.3% in 544 free-handed pedicle screws versus 5.4% in navigated pedicle screws. Let me emphasize that as a spine surgeon, it's important to not become wholly dependent on navigation. And as previously stated, understanding lumbar anatomy is key. The third objective of our talk is the spectrum of approaches. You can pick your approach. This diagram illustrates the different approaches the spine surgeon can take to access the lumbar spine. You have the posterior lumbar interbody fusion, the transforaminal lumbar interbody fusion, the anterior lumbar interbody fusion, the oblique lumbar interbody fusion, or anterior to the psoas muscle, or the lateral or direct lumbar interbody fusion that traverses the psoas muscle. This is a very loaded term these days, minimally invasive spine surgery. One of my mentors, Ian Kalfas, would always harp on me that there is no defined description of quote unquote MIS surgery, but everybody's asking for it these days. He'd always tell me that he does minimally invasive spine surgery every day. The colloquial definition, though, perhaps may be thought of as a relatively new approach. Newer approach is meant to minimize quote unquote invasion and minimize quote unquote risk. Invasion refers to the extent of soft tissue and bony disruption, and also neurologic and mechanical sequelae after the initial surgery. The different approaches are the result of changing patient expectations, increasing demands for shorter hospital stays, and a return to work as soon as possible. The big goal of this quote unquote minimally invasive spine surgery is, can we reduce operative time and achieve faster recovery while also having fewer complications? The disclaimer is, though, that new does not guarantee better. Be always skeptical and critical of new techniques. Our options for a posterior bony fusion from a posterior approach, we can fuse the spine in multiple ways. We can do the dorsal onlay bone graft with decorticating transverse processes as previously described. We can do a posterior lumbar interbody fusion. We can do the transforaminal lumbar interbody fusion as well. The posterior lumbar interbody fusion was first described by Briggs and Milligan back in 1944. Access to the disc space is obtained posteriorly. The advantage to this approach is that the vast majority of spine surgeons are familiar with it. You have excellent visualization of the nerve roots, and you can also get adequate interbody height restoration. The disadvantages, though, are that it's difficult to restore coronal imbalance and restore lordosis. It's also difficult to prepare the end plates relative to the anterior approaches. There's also increased risk of dural tear, and there's a risk of retraction injury of nerve roots causing fibrosis or chronic radiculopathy. Another option, which is probably more pronounced, at least it was in my residency training, was the transfemoral lumbar interbody fusion, the TLIF. It was an addended PLIF technique created kind of addended back in 1982, where it was a direct unilateral approach to the disc space. The advantage of this was that there was a reduction of damage to anatomical elements, preservation of ligamentous structures. Additionally, an MIS approach can even be used. A single unilateral incision can provide bilateral anterior column support. The disadvantage was that it's difficult to correct imbalance and restore lordosis as well, in addition to PLIF. Could be paraspinal iatrogenic injury with prolonged muscle retraction, and end plate preparation again is more difficult than the anterior approaches. The anterior lumbar interbody fusion is another option where we can gain access to the entire ventral aspect of the exposed disc, typically the L3 to S1 levels, most typically for L4-5 and L5-S1. The MIS history of the ALIF is that it can even be done laparoscopically. Unfortunately, the greatest complication of this was often implant malposition, and the studies often show that it required a reoperation when this was the case. Typically, we will have an access surgeon gain us access to the L4-5 or L5-S1 disc spaces to avoid damage to vital organs and vessels. The advantages of the ALIF is that it provides a direct midline view of the disc space and extensive lateral exposure of the vertebral bodies. Good for restoration of lordosis and foraminal height restoration, aka an indirect decompression. It provided an advantage for rapid end plate preparation when compared to the TLIF or PLIF. And there's a very, very high rate of fusion, at least 95.1% fusion over 4 years. The disadvantages were that there was a risk of vascular, visceral injury, and also in young males, retrograde ejaculation. The complications, I think, are really, really important to discuss, given how often this approach is utilized. With regard to vascular injury, there is at least a 6.1% complication rate, according to some studies. That includes venous injuries, risk of DVT, all elevated with an elevated body mass index and higher blood loss. Postoperative ileus is also a risk given the retraction of abdominal organs. And retrograde ejaculation has a 1.9% occurrence, which may give a surgeon pause when thinking about doing an ALIF in a young male. The prevailing theory behind this is that there's compromise of small nerves overlying the L5-S1 junction, which may innervate the sphincter valve that propels semen forward. So one reason why monopolar electrocautery is avoided. It's important to be aware of the vascular anatomy. Look for the level of the bifurcation of the iliacs and also venous structures that may be obstructing access to the desired levels. Again, complications continue with interbody cage subsidence with this technique, associated with larger cage sizes and increased reaming depth. The next approach is from Lateral, called the direct lumbar interbody fusion, which is the lateral retroperitoneal trans-psoas approach to reach the desired disc space, adequate for T12, L1, L4, 5 levels. The advantage is that it may be very useful to correct coronal deformity. Disadvantages, it's not shown to improve regional lumbar lordosis or global sagittal alignment. Neuromonitoring is necessary given that we're going through the psoas muscle to avoid injury to the lumbar plexus, in addition to risk of bowel injury as well. The next approach is the OLIF, another lateral approach for levels L1 and S1, providing access to the space between the anterior vessels and the psoas muscle. The advantage is that We do not need to dissect or traverse the muscle. Neuromonitoring is typically not needed, and it's useful in correcting sagittal and coronal deformity. Complications would include incisional pain, possible sympathetic chain injury, and also vascular injury. When you have all these options, it's important to compare the different approaches in terms of efficacy of fusion. There are plenty of studies that do this, comparing one approach over another. These are just a few to keep in mind. Zhang et al. Compared the TLIF versus the PLIF, where the PLIF showed an increased complication rate, increased operative time, increased durotomy rate, but neither is superior in terms of clinical satisfaction or radiographic outcome. Fan et al. Compared ALIF versus TLIF, but found no difference in fusion rate, but other than dural injury higher with a TLIF and a vessel injury higher with an ALIF. And then ALIF versus lateral lumbar interbody fusion versus a TLIF, where Watkins and al. Analyzed 220 consecutive patients who underwent the different procedures, where there was an improvement of a lordose significant in ALIF and lateral lumbar interbody fusion, but not a TLIF. But all were able to significantly reduce spinal listhesis. And then there's the future. The following techniques and innovations are only a small taste of what lies ahead. We have another potential new approach with the prone transpsoas position, which provides lateral access and circumferential access to the spine. The advantage is that it's a familiar position where gravity is able to be utilized to increase lordotic correction. You can get MIS access with a reduced risk profile, and the learning curve is also decreased given the familiar prone position. This is a photo that shows the surgeon in the operating room and the patient in the prone position. And this is the L3 to 5 fusion that has taken place with the interbody done from the prone position laterally. Next generation materials for the interbody. Silicon nitride has emerged as a ceramic implant that's being considered. It's biocompatible and osteoconductive. It may even be superior to PEEK, but studies are currently in progress. Bioabsorbables. Magnesium polymer cages are currently being considered. Unfortunately, they do not have any osseointegration. The goal of the ideal bioabsorbable would be degrading with time, encouraging osseointegration, and has an elastic modulus that's similar to bone. We also have enhanced coatings of the interbody cages. The first is hydroxyapatite coating of the cages, which has been shown to crystallize collagen to create a bony matrix in goats. And then there's TGF-1 and IGF-1, which stimulates replication of the osteoblast, leading to creation of a bone matrix. Both have been shown to have decreased spine flexion extension when compared to cage alone in goats. Here is an electron micrograph with the top left showing PEEK with hydroxyapatite coating at 80,000 magnification versus B, which is PEEK with the coating at 10,000 magnification. The lower two show the uncoated PEEK at 80K and uncoated PEEK at 10K. So the point of this is to show that the coating has stimulated a bone matrix to be formed. And then there's technology in the future. Robotics has entered the spine world. Across the surgical specialties, robotics has allowed for improved dexterity, tremor elimination, and potentially image magnification. For spine, robotics has the benefit of offering an alternative to radiation-intense freehand pedicle screw placement. The technology allows for preoperative imaging and trajectory planning with short intraoperative registration. Prior studies have also found with imaging that whether it be with robotics or neuronavigation, there's 99% accuracy for lumbar screw pedicle placement versus 92% freehand. But more studies are needed to approach zero error pedicle instrumentation. Robotics may be an answer to that. There's also telesurgery. There has even been discussion about the use of telesurgical robotic systems for posterior-based surgery. But further application may even involve resection of intradural and extradural tumors in this aspect. Of course, humans, I believe, will always be at the helm. In recent years, there's been the emergence of machine learning and artificial intelligence in spine surgery. It has been used to determine which treatment will result in the most optimal outcome for patients. Additionally, machine learning has emerged intraoperatively in the form of augmented reality. Shown is an image of what a surgeon would see in real-time screw trajectories, so that a surgeon will never have to look up from the surgical field to look at a navigation screen, but will see it in real time in their field of vision, looking at the wound. This is all expensive, and given the new technologies and techniques emerging, it will only become more expensive. The rate of spine fusions has actually increased dramatically over the last 40 years. Costs are rising as well. Between 1998 and 2006, there was a 408% increase in costs for a primary spinal fusion. This includes cervical fusions as well. With the rising number of fusions and increased costs, there was a total expenditure of $29.1 billion in 2006 in the United States. Beckerman et al. Actually recently did a retrospective cost analysis at their institution of single-level lumbar fusions, all approaches from 2008 to 2012, and they showed a mean direct cost of just under $23,000 for a single surgery. But the highest estimates in other studies can actually get greater than $80,000 for a fusion case. The highest mean for cost was for the circumferential approach, and the lowest for a posterior instrumented fusion without interbody cage, or the dorsal onlay grafting that we discussed earlier. But there was no statistically significant difference among the various interbody fusions for fusion rates and costs. Per Modern Healthcare publication, implant costs comprise at least 37% of all costs in the OR. As more sophisticated implants emerge on the market, these costs are likely to increase. Globally, the spine implant market is projected to reach $13.8 billion by 2025, with a compound annual growth rate of 5%. As you can see, there are pretty huge market forces at play here. This recent article from October 2021 questioned the efficacy of spinal fusion, criticized the indications for the fusion, in terms of the wide indications and wide variability of surgeons performing the procedure, and also criticized the medical device industry for expensive products that do not undergo the stringent testing by the FDA that the medications usually do. Regardless of the accuracy of this article, which perhaps can be questioned, I am more concerned with how patients perceive what we do as physicians. I do want to reference a meta-analysis from 2017 that analyzed lumbar fusion outcomes across 65 studies, which included 19 randomized controlled trials covering over 300,000 patients going back to 2012. The study actually found that positive outcomes were most compelling for patients with spondylolisthesis who were experiencing low back pain and leg pain, where the patients that were randomly assigned to fusion were 4 times as likely to be satisfied and achieve a 40% improvement in preoperative disability versus non-operative care. I think that, armed with the correct indications for fusion in terms of spondylolisthesis, we can make the right decisions for our patients. But it's also ultimately up to us as physicians to educate our patients and the public for what we do. So what do we do with all of these options and all of these approaches and all of these interbody cages options and all these technologies? After decades of rising costs in American healthcare, there is now an increased emphasis on cost effectiveness and value-based medicine. Larger cohort studies are needed to determine the true comparative efficacy and complication rate between open and MIS approaches, freehand and robotic pedicle screw placement, or with computer-assisted navigation, and between the various interbody fusion materials. The real question to ask is, what is best in your own hands and your own experience in caring for your patients? Find the right approach for each complex problem. returning to our objectives, we've hit all of them in this relatively short overview of this huge spine topic. I think it's an exciting time to be a spine surgeon, given how far this field has come and where it is going. I hope you gain a better understanding of the materials and approaches to fusing the lumbar spine in hopes of providing the most optimal care for our patients. Thank you.
Thanks, Bill. That was great. As you said, each one of those subtopics is a grand rounds presentation in and of itself. So you sort of gave us a 30,000-foot, very fast, very fast view. But very very nice job. Well constructed.
Well done. I like the materials part. That's something that I think is underappreciated. We tend to be anatomists and think about that, but surgery really involves everything: wound healing, materials, stability, physics. Well done. Questions for anybody?
Bill, this is Than. Nice job on that talk. My question is, we talk about the new technologies, navigation, robotics. What are you kind of hit on the point that it's very expensive. My supposition is that in North American, European healthcare, we tend to build things based off of a very robust infrastructure. Do you think that what we need to do is change our mindset a little bit and think about the fact that if we want to increase the adoption of new technologies, that they have to be available for more globally and in less infrastructure heavy locations, things like that?
Yeah, I think you and I have talked about this a lot, in particular in terms of like what the standard of care is, and like navigation is not the standard of care. For placement of instrumentation. I mean, the third world, for instance, is not relying on computer assisted navigation for placement of implants. That they're using the anatomic landmarks that all trainees should know how to do. I'm split on that because I do think that the technology, if it's available, and can be used in a cost-effective manner, it should be. And in terms of improving patient safety, I think there may be a responsibility to use it. Do I think that because certain regions of the world can't use it, it shouldn't be used at all? I don't believe that. What I do think is that the standard should be just raised, globally, if as much as possible. That if there was a way to, make things affordable for the third world, which I think is possible, it should be attempted.
You would be surprised at how much of this technology can be made available if we think creatively about where we make it, how we supply it. The story of shunts is well known, but we're now getting microscopes into the low and middle income countries very commonly, drills following, and I think navigation will be close behind. The biggest problem, though, is maintenance of these machines. That's the equal problem, I should say. But
Right.
it'll come.
Yeah. So I think that this your whole talk, Bill, is kind of a storyline of resource heavy countries, and instrumented fusions are not, especially for degenerative problems, are not a worldwide phenomena, and so we have to be cautious as we move forward as the stewards of these types of technologies and treatments, to make sure that we're actually doing them for the correct reason versus just doing them because we can. And Dan has been very much on the forefront of that over decades, pointing out that just because we have a new widget or new technology or a new coating for a cage doesn't necessarily mean we have to have it, because guess what? You could just take the iliac crest and put it in there, and that worked for decades before we came up with these things. So it's a cautionary tale.
I think One in my research on, spine fusion, I guess, I've always been told that, it's done too much, but I have to say I was pretty appalled by by the news articles that I was reading about lumbar fusions. I mean, we are made to sound like criminals in terms of what we do, and it's and you can kind of tell when people come into the office and with back pain or whatever, and they're extremely fearful of spine surgery because they've heard the terrible stories. And I think honestly, what it comes down to, it really is a procedure that's probably done way too much, and we've kind of gotten a bad name for it.
Yeah, and I think probably Dan, if he's still on, could comment on this. It's education within residency, but then it's also some oversight through the respective boards, neurosurgery and orthopedics, on what happens after you get done, and whether or not you can kind of course correct people who are kind of focused on the monetary benefits of doing fusions as opposed to the benefits of the patients. So that's really important. I personally don't really, unless I have to do a fusion, don't really like to do it because it's a whole lot of work, right? And when you actually calculate out the math, if you do 4 to 6 microdiscs or laminectomies in a day, you will get reimbursed just about as much as if you did 2 or 3 fusions, but you're going to feel like you worked a lot harder doing the fusion. So people have to be cautious about how they think about these things as big, the bigger the operation, the better it is for them and the technologies that they have. But rather, if you can do the lesser operation that gets the patient the right benefit, you will do just as well, both for the patient and for yourself. So it's important.
Well, totally agree.
Very good. Thanks again, Bill. Well done.
Thank you.
Thanks, Bill.
Thank you.